Hi everyone, my name is Alex. I'm going to be going over your Unit 4 Immunology lectures with you. So the way that these lectures will work is all of your lecture notes are going to be fill in the blank style. The first set is a little bit different from the rest, but so I will give you guys the information that you need to either summarize or directly fill in the missing words. And after we go over each lecture, I'd really like for you guys to go and take the quizzes that I made for you on Canvas. It's best if you try to take them without looking at your notes to practice active recall, which I think is really good for helping you guys do better on your tests. It really doesn't matter if you get them right or wrong. You can take them as many times as you want. The important part is that you're trying to bring up the information that you just learned, and that's been proven to help people do better on tests. So it's for your own good. Use it, don't use it, it's up to you guys, but that's what I've made for you guys for these lectures. And this first set is a little bit different than all the rest. The rest are going to have pretty much just individual words or phrases for you to fill in. This one has some larger fill in the blanks. I will be going over kind of the basics, and if you feel like you want to summarize or if there's a keyword here or there that you want to write down, that's what you can do for these lecture notes. So let's go ahead and get started with lecture 1, which is Strep Serology. So here are your objectives. Alright, so strep are gram-positive spherical, ovoid, or lancet-shaped organisms and are often seen in pairs or chains. They were first described by Pasteur, and they are catalase-negative, facultative anaerobes that comprise a heterogeneous group of homofermentive bacteria whose principal formation product is lactic acid. Strep pyogenes, group A, beta hemolytic strep, is a major pathogen of the genus. The organism is only found in humans, and person-to-person spread is usually by upper respiratory secretions or by direct contact. In humans, the two major sites of infection are the upper respiratory tract and the skin. Strep pyogenes is in fact the most common cause of bacterial laryngitis, which is sore throat, in children between the ages of 5 and 10, and about 20% of school children are carriers of group A strep, but they remain asymptomatic. The most common skin infection caused by group A strep is pyoderma, or impetigo. Separative or pus-producing complications are those in which white blood cells accumulate in a localized area where the organisms are found. This can include otitis media, scarlet fever, cellulitis, those kinds of diseases. And then the more serious ones are going to be sepsis, septic arthritis, acute bacterial endocarditis, and meningitis. With non-separative complications, the inflammatory response is present, not in the infected areas, but somewhere else in your body. The inflammatory response can result in acute rheumatic fever or acute post-streptococcal glomerulonephritis. Both of those are thought to be an autoimmune response involving cross-reactive antibodies. So in the case of acute rheumatic fever, the antibody binds to myosin in your heart and skeletal muscles, and in post-streptococcal glomerulonephritis, the antibody reacts with your glomerular basement membrane. And serology testing plays a major role in diagnosing both of those diseases. So the serogroups of streptococci are determined by the C carbohydrate of the cell wall. So fill that in, the C carbohydrate of the cell wall. The group carbohydrate divides strep into 18 different groups designated A through H and K through T. These are known as the Lansfield groups based on Dr. Rebecca Lansfield. All group A strep are antigenically identical for this carbohydrate. Serotypes of group A are determined by the proteins in the cell wall M, T, and R. The M antigen is the chief virulence factor for this group, and there are 80 antigenically distinct M serotypes. So rheumatic fever follows a strep throat infection, and post-streptococcal glomerulonephritis can follow either strep throat or pyoderma. The diagnosis of these conditions requires assays that measure the presence of antibodies to enzymes produced during the strep organism during acute infection, because most patients that present with these conditions no longer have the strep infection evident. All right, so rheumatic fever follows about 2 to 3% of patients with laryngitis. Both males and females are equally affected, and it is related to the production of antibody to the strep. So rheumatic fever does not develop in patients who fail to produce antibodies. If you don't make antibodies to strep, you're not going to end up with rheumatic fever. And although it's been observed in many age groups, the most common is between 5 and 15 years old. The process that leads from strep throat to rheumatic fever is still unknown. It's proposed that because group A strep share antigenic determinants with some of your host cells and tissues, that antibodies made against those can turn into autoantibodies. This is a non-suppurative inflammatory process involving connective tissue, and it results in injury to the heart, joints, and central nervous system. Rheumatic carditis can become chronic and progressively debilitating. And as far as the history goes, rheumatic fever and rheumatic heart disease were the leading cause of death in 5 to 20-year-olds during the 1920s, and it was only second to tuberculosis in those 20 to 30 years old. So now moving on to acute glomerulonephritis. This is secondary to a group A strep infection. It occurs with varied attack rates ranging from less than 1% up to 18%, manifesting primarily in childhood. It is thought that the syndrome is immunologically mediated, and the most commonly accepted theory for this disease is that the circulating antigen-antibody complexes are deposited in the glomerular basement membrane, where they activate complement and damage your kidneys. The result is from complement-mediated release of lysosomal contents from white blood cells. So we have a couple lab assays that we can use, and these are the serologic means that are able to demonstrate previous group A infections. So ASO is anti-streptolysin O, and that is positive in 80% of patients with rheumatic fever, but it is rarely positive for acute glomerulonephritis. So ASO is good for testing for rheumatic fever. Anti-hyaluronidase testing is somewhat positive in both rheumatic fever and acute glomerulonephritis. Anti-DNase B is the most reliable for both. Streptozyme is mainly used as a screening test. So now we'll get into the details of these. The ASO test uses streptolysin O, which is an oxygen labile enzyme. It is produced by most strains of beta hemolytic group A strep. The antibodies to streptolysin O neutralize the hemolytic activity of this. So an increase in titer of ASO indicates a recent infection with group A strep. In 75 to 80% of patients with rheumatic fever, the results will show an increase in ASO titer. And this assay is linked to the upper respiratory sequelae. Streptolysin O is produced by group A strep in pyoderma, but it is then bound by the cholesterol in the skin. So this is why the ASO titer is rarely positive, because no antibody forms. The ASO titer was the first test developed to measure streptococcal antibodies, and this test is based on the neutralization of the hemolytic activity of streptolysin O. The range of expected normal values is variable and depends on the patient's age, the geographical location, and the season of the year. Typically, however, a single ASO titer is considered to be moderately elevated if the titer is at least 250 Todd units in an adult and 333 in a child. The traditional ASO titer involves dilution of a patient's serum to which a measured amount of streptolysin O is added. After a proper incubation period, red blood cells are added as an indicator, and if enough antibody is present, the streptolysin O will be neutralized and you will not see any hemolysis. The titer is reported out as the reciprocal of the last tube showing no hemolysis. This can be expressed in Todd or international units. A fourfold increase in titer between the acute and the convalescent sera is evidence that you've had a recent group A strep infection. And there can be false positive titers associated with liver disease, with the growth of bacteria in the serum specimen, or caused by oxidation of the streptolysin O reagent. Alright, so here you have your image of your titer. You have a red cell control tube and a streptolysin O control tube. And you need to make sure you know that in order for your test to be valid, the streptolysin O tube should be complete hemolysis, and the red cell control tube should have no hemolysis. Otherwise, your test is not going to be valid. So there's also an ASO rapid agglutination test, and that uses latex. So this is a screening test using polystyrene particles coated with streptolysin O that will agglutinate in the presence of streptolysin O antibodies. We also have a streptozyme test, and this is a screening test for the detection of antibodies to 5 streptococcal enzymes, and those are DNase B, hyaluronidase, NADase, streptokinase, and streptolysin O. The slide test is a passive hemagglutination assay that employs sheep blood cells coated with streptococcal enzymes. The reagent is mixed with the dilution of patient sera, and if you have antibodies to any of these enzymes, you'll see agglutination. So for this, agglutination is a positive reaction. If the test is positive, then the serum can be diluted further to determine the streptozyme titer. The titer is the reciprocal of the highest dilution showing agglutination. Next, we have anti-hyaluronidase, and this assay can be used for both throat and skin infections. This is a neutralization assay in which antibodies to the enzyme are allowed to neutralize it, and that prevents the breakdown of the substrate potassium hyaluronate. A dilute acetic acid is added to the tubes, and in positive patients, there will be the formation of a mucin clot. The titer is the reciprocal of the highest dilution with definite clot formation. Next, we have anti-deoxyribonuclease B, and group A strep produces DNases A, B, C, and D. DNase B is produced by nearly all strains of group A, and they are produced by strep organisms in the throat as well as the skin. The test is thought by many to be the most reliable assay of the group A strep infections, and anti-DNase B is a neutralization test, Antibodies in your serum will prevent the enzyme DNase B from depolymerizing DNA. So the presence of DNase is measured by its effect on DNA methyl green conjugate. This complex is green in its intact form, but when it's hydrolyzed by DNase, it is reduced and becomes colorless. So an advantage of this method over the ASO titer is the stability of the reagents. DNase B enzyme can be stored for 2 to 3 months, whereas ASO reagents have to be used within 8 hours. So that was quick. I want you guys to try to go and take the quiz. These quizzes are really short. Most of them only have 3 or 4 questions. They're either going to be like one word fill in the blanks, multiple choice, or matching. So go ahead and try to take that, and I'll see you guys in the next lecture.